Welcome to Healthcare Quality and Risk Matters. Wondering about patient safety, quality, and risk management, but aren't sure who to ask or were afraid to ask? Well, you're in the right place. We've created a safe and judgment-free space to explore these critical topics to leave you informed and inspired to make a positive impact on healthcare. So, let's learn and grow together because healthcare matters.
Well, good afternoon, everybody, and welcome to this June installment of Healthcare Quality and Risk Matters. My name is Gary Bierc. I'm the CEO of Aperitisoft Healthcare. I am joined by Rob Santamoor, our Chief Operating Officer, and Dr. Timothy Brown, who is our lead and head of customer success in the healthcare solution area. So we are just delighted to be here with you today. Just for you guys to know a little bit about us, Rob is a registered nurse, been practicing for some 20 years now. Most of that time, though, he has been working in the quality and risk area within hospitals, including Donate Life in that area. As a bedside nurse, he has worked in hospitals as well as in Donate Life in his career. So he has a really good blend of experience, both bedside and on the clinical side, as well as within quality and risk. And we got Dr. Timothy Brown, who has a PhD in hospital administration, has worked on the administrative side within hospitals, has some 15 years experience doing so, and brings a really interesting perspective balancing between the clinical and the business aspects of healthcare. And I am the risk geek of the bunch. I've got 40 years experience in risk management. It seems like in every aspect of my career, I've always been doing risk, even today as CEO of our healthcare company. So very delighted for you all to be here and joining us. I am excited, guys, about our episode today because we're talking about disparate systems. And the reason why I'm excited about it is that is one of the key reasons why we even formed Aperitisoft Healthcare to address this problem, because it seems to be a critical issue that eventually can affect patient outcomes, can affect the reputation of a hospital, and even ultimately the revenues and earnings, if that is a tertiary issue that we'd want to approach in all this. And then we in Aperitisoft Healthcare clearly have addressed this, and our whole product is about fixing this problem. For you folks that are joining us today, please let us know where you're from. Go ahead and get in there into the chat. Tell us where you're hailing from. We'd like to know as we're going through and monitoring your questions. Pitch questions at us throughout the session today. We'd love to hear what you're thinking about, as well as maybe pick at us a little bit and see if we can get you the answers that you are looking for. If you're not familiar with our format, we will begin with something called Incident of the Month. Then we will follow that with what we call Minute Matters. Minute Matters is where we do a round robin of questions to each other, and whoever fields the question only has 1 minute to answer. And then after that, we'll try to pick up all of your questions out there as well. We'll see where the conversation goes. The key is let's have fun while we're doing all this. So with that, Rob, I know you cannot wait to give us this incident of the month, because it is something. Tell us what you're going to share with us this month.
So this month, instead of pulling an incident from mainstream media, we decided to share. There's an audit that happened in real life to me. That really spoke to the problems around disparate systems. So I'm just going to tell you the story of what happened, and then we can talk about it further from there.
Okay.
So starting my day, hanging out my office, doing my standard work, and I get a call from security that Department of Health is standing in our lobby. So of course I have to run across campus to go get our auditors. And I see 5 auditors sitting there waiting for me. They inform me that they're there for a complaint, right? Not that weird, not great, but that it's a complaint regarding a patient grievance. They hand me a 2.5-page list of requests. They then separately request a very specific grievance itself. So they wanted This grievance was a potential federal law violation by the carrier,
Ooh.
right? So not
Ouch.
great.
Mhm.
And a potential patient care, patient safety concern.
Wow.
So I open our incident management system where incidents are reported at that hospital. And after about 45 minutes, I was able to locate the incident. I was stoked. I found it. Unfortunately, the documentation was severely lacking. So this facility's quality management system is comprised of 5. There's disparate platforms that they piece
Okay.
to make an
Mhm.
entire quality program. So then I had to go to email and reach out to 2 of the risk managers to assemble, well, how did we respond to the incident? My incident management system, we documented it, but how did we respond to it? So we have to do that through email. One of the incident managers says, well, hey, I have some responses. That are 10 months old. Took 3 hours to find. Then I had to go to the other risk manager to find the corrective actions. That are documented on an Excel spreadsheet that he keeps on his computer. Says what we're gonna do. So the CAPA documentation again was unfortunate because the only thing we documented was what we were going to do, but nothing that we did.
Huh.
Right.
Wow.
So then I needed to start making phone calls. So I had to call the staff that were on that day, the managers, the supers, etc. Right, security, everybody. Calling them at home. They had just gone to bed. Right, they work nights. Disturbing them. Everybody that was involved in the incident, and ask them to search through their emails. To see if they could find any supporting documentation at all that we did what we said we were going to do.
Knowing auditors, they must have been pulling their hair at this point.
They were
Correct.
becoming more and more furious by the minute. So that phone call process, just that part of the process, was 40 phone calls, and it took 4 hours.
Wow.
Wow.
And throughout all of this, I'm pulling policies from SharePoint, the document system that they were using. And they don't have like a support staff, so I'm having to do all of the policies through SharePoint, and it took over 2 hours just to pull SOPs, work instructions, and trainings. From another one of their systems, right? SharePoint for document control. Unfortunately, I could not tell which ones were controlled documents, which ones were just random uploads. So it took me a really long time to figure out what was appropriate to turn over and what wasn't. Assessments that I should not be having to make in real time, right? So during all of this, the auditors are touring our building. They're interviewing staff. And they've completed all of their in-person and observable assessments. And they're sitting there twiddling their thumbs, waiting for me to get their list together. They're growing more and more irritated that I'm not providing them, honestly, the very simple request that they had.
Mm.
Once I had finally assembled, there's all the documents from SharePoint, Excel, the incident reporting platform, emails, in loose leaf paper. I had to put together, there's a packet with a key on top to make all of the documents tie together to make it make sense, right? Because it's just all of these pieces of documentation. So when I turned over the packet that they requested, the look of frustration, disappointment, and confusion by the auditors was definitely a low point in my career. I will add, I was new to this hospital. And I was not in charge of those processes. My level of embarrassment was extreme. My face was red, and I just knew from a quality perspective we had failed. At that point, the auditors looked at that. They decided they're not touching it. They're going to go home for the day, and they're going to come back the next day. They ended up being there for 3 more days, when realistically it should have been a day. By the end of the audit, I had made 71 additional phone calls. I had tracked 14,000 steps for just the audit activity, and I had worked across 5 platforms to try to prove that we did the right things for the right reasons. We were not able to prove that. We were not able to prove adequate corrective actions. We were not able to prove implementation of processes as outlined by our standard operating procedures. And all because our poor documentation was able to find these floating disparate things in cyberspace and on people's desks and Post-its.
How much did this cost?
So it led to multiple conditional level findings. significant financial penalties with extensive corrective action needs. The penalties associated with the cost of poor quality, it was over $4 million.
Oh, my word.
Wow. Okay.
Okay. All right. So, I mean, that's a nightmare.
Whew.
It was one of my worst. Yep.
So, Timothy, I know, we talked briefly before the show about this a little bit, and you've got, a bunch of things swirling in your head. Why don't you lead us with the questioning on this whole thing, and let's peel back this onion.
Yeah. For one, $4 million fine for an issue that should have taken 1 day, but really took about 4. I'm just completely blown away at the entire executive team. I know they probably had a field day with your quality team, and really just understanding how to find these issues. I'm completely mortified by that overall process. So sorry for you, Rob. I think the only silver lining to this is you did get 14,000 steps in a day. That's what we want to see. That is that's atrocious to hear. One thing I do want to ask you though, Rob, because I know you mentioned this multiple times throughout your entire monologue of this overall incident. You talked about disparate systems, and one of the primary challenges of really using a disparate management system in healthcare is the fragmentation of data. Mm-hmm. So can you define for the context of everyone listening today what a disparate system is, and what are those common challenges that tend to happen in organizations when they face these integrated disparate systems across in their workflows?
Yeah, so a disparate quality program is there's a set of platforms used, whether that be paper or pen or electronic or combination thereof. There's to manage quality, risk, and compliance within your organization. So if you're using more than one, you have a disparate quality program where you have physical gaps and electronic gaps, people-driven processes in between platforms that, of course, in itself creates significant risk to the organization and your patient.
Correct. Absolutely. And the overall issue that you had was really focused around a patient flow issue. So you have multiple systems that are trying to manage one patient. Think about multiple patients in those multiple systems. It's very easy to lose something as simple as an issue or a patient complaint, which is what this overall incident is talking about. So I appreciate you for answering that. Gary, I know you're going to talk about finances, so I'll save my questions around finances.
I'm still spinning on $4.5 million being a former CFO. Well, I don't know how does this hospital typically deal with this? I know it could be different from CFO to CFO, but are they budgeting for this, Rob? Or is there some place, a bucket that they go to pay these costs? Help me out.
So I agree. It is different from CFO to CFO, right? Each hospital or hospital system has a different process. There's some that I've seen that are more planning ahead, right? Let's use giant air quotes with that. They budget for their cost of poor quality. They budget for the fines. They budget for the penalties that they have to turn over for poor quality.
What do these budgets normally look like? So if I said to you it's a 200-bed hospital, how big would that budget be in that scenario?
I've seen them set aside anywhere from 5 to 10% of their entire revenue line.
That's correct.
Wow. So 150-bed hospital is what, about 300 million in revenue?
Yeah.
So that could be anywhere from $15 to $30 million are being set aside.
Just setting it aside, knowing that revenue is generated but not retained.
Wow.
Others pull it out of.
This is another big question. I know I'm geeking out on the CFO side here.
Jeez.
Are they analyzing this, and when they budget for the next year, it's based off of knowledge of the risk in this area, or are they just carrying it forward? And just that's their answer. Have money set aside. Help me to understand that from a decision-making perspective.
Yes, so I've seen them carry it forward, and you said their knowledge in this space, so they're being predictive, right? They're trying to grow it, so to me, I feel like the people that are doing that are acknowledging that there's a problem.
Correct.
And they're just budgeting for the problem to continue.
So they're addressing the consequential side of the problem. They're not dealing with the root cause and
Yep.
and the frequency of the issue, which
It's the Band-Aid on a hemorrhage. Yeah.
And I know this isn't what you asked, but I have a massive frustration with that. And it is, why are we budgeting for poor quality when we can budget less for better patient outcomes?
Exactly.
Like, I just
And
don't.
that is
You had a
money.
bell to ring on that one.
I mean, when you think, and I'm just thinking about the financial interconnectivity here. Okay, if we are content with just this happens from time to time, and we're just putting money aside and not getting at the root of why they're happening, and trying to correct it, and having a system that does so, then we're letting the cost of quality just kind of cost of healthcare just run away from itself.
Absolutely.
And using it as that's the excuse of why healthcare is the way it is. Well, no, it doesn't have to be that expensive. We can lower the cost of healthcare through quality and increase the revenues of a hospital.
Yep.
Absolutely.
It doesn't make sense to me.
So the audit that we talked about as our incident, there's, in my interviews and in the documentation that I can see, I was confident that if a family member of mine was at that hospital, that they would actually be getting good care, but I couldn't prove it. So they are sacrificing. There's that $4 million. And proving to the community that they are operating under poor quality when really they're not. Right? So they're not able to share with the world how smart they are and that their heart is in the right place, right? They care about the patient. They just can't prove that to anybody else outside of people doing the work.
So Timothy, if a hospital, this is a hospital administration question, if a hospital is not budgeting for bad things to happen, so in effect reserving that fines and lost revenue are going to happen, okay? I assume they throw lawsuits in that too, in that bucket. Yep. Is that correct?
That's correct.
So they're putting a bucket in for that. What do they do then? If they're not setting it aside, then what do they do?
If you plan to fail, you are pretty much setting yourself up for failure if you're not planning for it. So if they're not budgeting for this, then when these incidences do happen unnecessarily, they have to take this money from somewhere. So it's reallocation of funds from other budgets. The main goal of a CFO really is to identify those overall risks, to kind of project the overall financial forecast and cash flow projections. However, if they're not including that understanding of where these potential risks, such as this incident that costs $4 million, I don't know who can just find $4 million, but you're working a complete miracle, or you're stealing from an area that really could potentially use that overall fund. But if you're not budgeting for it, then you're setting yourself up for failure to have to pull that money from areas that actually need those overall funds.
So, Rob, I have another question for you. All right. So, knowing Aperitisoft Healthcare, okay, and Aperitisoft Healthcare links all of these disparate systems together in a seamless workflow so that the hospital quality and risk team are managing these things from left to right into conclusion, and then they're being retained in the system forever. If you were working with Aperitisoft Healthcare and that auditor walked in the door, what would the outcome have been?
It might have taken me, depending on the interviews, almost 6 hours to do the audit. And mostly my time spending alongside the auditors, answering questions and supporting my staff, right? Because my system allows me to click on my incident, and pull up my entire documentation process, my entire quality risk management process. And essentially just hit export to printable form and turn it over, right?
Right.
So I think the huge difference is I wouldn't be hanging out in my quality system because my quality system did its job. My quality system would allow me to prove that we did the right things for the right reasons. I'm sitting with my staff, I'm sitting with my auditors. They leave after being there for 6-7 hours with a thanks, have a great day. We don't expect any citations. See you next time, right? So no fines. Staff feel supported. and we're able to prove to the community that grandpa's safe at our hospital.
I love that.
I think that, guys, we have a lot more to talk about on this, and I think we should transition to Minute Matters. Well, let's show our audience a quick 20-second video of how maybe somebody may be experiencing just what you described.
Absolutely.
Sure.
I love that video, Rob.
Yeah.
Because the frustration that you were going through, you can see it on the face of the young woman in the beginning. But, you know, with the Aperitisoft Healthcare, obviously, we're taking all that pain away and, you know, making this process a whole lot easier for quality teams. Timothy, I know you got more questions, so go ahead, buddy.
I do. I just want to hint on a comment that Rob said that was very significant. Right before we went to the commercial, he literally said, "I just want to make sure that the hospital is safe for Grandpa." When it comes down to that granular level of we really are caring about patient care, I don't see how you could function in a healthcare organization that doesn't take quality serious and doesn't have that overall understanding of how to make things better for your patients. I think we hear across the board a number of healthcare systems that are saying, hey, we are patient first. We want to ensure that the patient has the best experience. But then you look at their quality systems and they're still literally manually writing things out in Excel or having little, like Rob said, sticky notes that they're trying to keep up with. What is it going to take for us to make that transition and change? And Rob, that's really going to be the question I'm going to ask you. What are healthcare organizations going to have to face in order for them to really make that significant change towards a better quality system? And I know you can speak hypothetically from your perspective.
Yeah, so I believe two things are going to happen. I believe that a new wave of leaders is going to come through that understand there's the need for intelligent programs, right? And understand that disparate programs create physical gaps that are people-driven processes in between, and obviously that's not okay. And then the other thing that I see happening in the future is the same thing that we've seen happen over the years, right? Quality didn't exist in hospitals, and then 80s and 90s, 2000s, 2010s, 2020s, it keeps growing. There's more regulation around it. We have to do more. I do believe at some point regulation is going to require more comprehensive quality systems to better manage these processes, just like they require that of electronic medical records, just like they require incident reporting systems now. But they require incident reporting systems, but they don't require capital management systems, right? So like some of the things don't make sense. And I think they're going to grow.
So Rob, we're going to turn the table. Why don't you ask either Timothy or I a question? You lived through that incident, right? And the pain of it. So you've got a risk expert, you got a hospital administration expert. What would you ask us?
So you kind of already asked it, but as a CFO, would you be able to put yourself in the shoes of a hospital CEO, CFO? Figure out why they believe that budgeting for poor quality is the better choice than budgeting for high quality. And
this is my perspective, and I'll let Timothy answer as well. Mine will be quicker than Timothy's probably. I believe that a lot of CFOs go with what they hear. And if the team around them is telling them, look, this just happens, there's not a whole lot we can do about it, we just got to put the money aside, then they're putting that money aside. And that is a false narrative. That's just not true. No one's really looking at the root causes here and determining why they continue to happen. I think if they did, the amount of money, I mean, we know we are a fraction of the $15 to $30 million budget set aside. But if they would realize they can knock whatever their budget is in half by having the right system, they'd be blown away. And that's my opinion. Timothy?
You are absolutely right. How long do I have? A minute? All right, start my timer now.
You got a minute. You're
Start
right
my
on
timer
the top
now.
of the minute right now. Right
I
on the
would
top
do
of the
my
minute.
best. Maybe I'll go over. But Gary, you hit the nail on the head for sure. The first thing I would really focus on is addressing those myths of this is the way we always done it. We've heard this time and time again in healthcare. And there's different ways to phrase it, but that is the bottom line understanding. We've always done it this way. We've always put these funds aside. It's just going to be how it is. And it doesn't necessarily have to be that. Gary, you also hit another nail on the head when you said having the right system to give them the data that makes the decisions is definitely a major portion of it. The other side of that is the cultural shift that we have to do different things. That's building out what your executive board team looks like. Is having the right people at the table to have the conversations to bring that data to your CFO, to your CEO, to your COOs, and those key players, your chief risk officer, those key players that are making decisions for your organization. It's going back to what Rob said last month. Your nursing leaders, even if you're not at that executive table, you have to be loud about what's going on in your individual departments. We have to create a culture shift to start talking about speaking across different departments and not working in overall silos. Building out those particular areas are really going to be where we start to see that ship turn and start to move towards a better off perspective for quality for our patients. But most of all, you're going to also see an overall shift in how work is done and how quickly we get things done in the healthcare organization when everyone's on that one unified mind towards building a better quality system.
Yeah. So, Rob, let me ask you another question. You're the process expert in how we're doing this. How is it that a system like Aperitisoft Healthcare makes the difference? I mean, we can make the claim, okay, but for the audience, hit all the pain points that disparate systems create. I'll give you a hint on what's on my mind right away. You've often talked to me about how long it takes sometimes just to put an incident in the system that's out there. And I'm assuming the reason why, a major part of that, is that system lives by itself. So now the bedside staff have to put a lot more in and figure out what that is. So it tries to create some tissue that can connect with the next steps of the process. But why don't you play off of that for me, if you don't mind?
Yeah, so from a high level, it is programs like Aperitisoft Healthcare. Aperitisoft Healthcare, the program. It runs a quality and risk management process. It's not a database. You're not dropping information in, right?
So it's just not putting data in and restoring or storing data. We are driving process,
which is what we're used to, right? We do Excel, notebooks. We do a good job dropping data in places. But when you have programs like Aperitisoft Healthcare, and you can improve those, you get things like the pain point. Nobody's documenting my incidents. Well, we can solve that, right? It's easy to document an incident, and I know something's going to happen with it. I, as a nurse at bedside, know that my quality and risk team are going to do something. My manager's going to do something because it's going somewhere. It's not just dropping in, right? So I am motivated to document, and it's easy for me to do it. I don't have to figure out codes and have all these like specific things that I have to reference in order to document. It's just what happened and what I did about it. There's simple, right? Then it moves through a track. There's a process, right? So quality and risk can then assess. Based on the level of need that incident has been labeled.
Yep.
So now I know where to prioritize my work. I know how to keep my patient safe and my staff safe. Then I can move into root cause analysis, apparent cause analysis. Do additional review and do my pre-risk work, and then move into my corrective action planning, all in a path, in a process developed that guides me through a risk process, rather than me moving data from spot to spot, from email to Excel to notebook.
Well said.
Right?
That's good. That's really good.
I hope that answers the question. So to me, Gary,
it does. And of course, we slap another little benefit, the cherry on top. We give you a score.
Yeah.
You can know where you stand with regard to overall quality by how each of those steps are getting accomplished.
That's correct.
And I think that's the feedback the CEOs and CFOs are looking for.
Absolutely.
There is something you
question
said. Sorry, go ahead.
Okay, go ahead, Rob. No, go ahead, Rob. I'll let you. Then I'll jump to the questions.
So, Gary, you had said this in the past when we were venting about disparate systems and what it does to our healthcare partners. You related it to a medication, and I think that was brilliant. Because that is what.
I shared with you guys. It just seems crazy that the way that hospitals react to all this stuff. So the analogy is that I've got AFib, right? And you guys remember when the event happened a few years ago, and the doctor said, I've got two choices in the hospital. I can have my heart stopped to restart it again to get out of this AFib episode I was in, or there's this new medication. And this new medication, he says, you take it now, you're going to have to stay in the hospital for 3 days. Mm-hmm. But you take this, it should get you out of AFib. And the amazing thing about it, this medication, I haven't had a blip since. I mean, it has been absolutely a miracle. What's happening with disparate systems is that everyone's being kept away from that magic pill. It's as though, I'm sorry, all I can do for you is stop your heart and start it again, because, you're going to have to stay in hospital 3 days to be monitored before we'll be able to do it. It just doesn't make any sense to me. If, me, the patient, it was obvious. My insurance allowed for me to stay in the hospital. I'm picking that path. I don't want my heart stopped. But the hospitals seem to keep picking the other option. No, we're just going to keep stopping the heart, right? That's what we're going to keep doing. And it's insanity. It's doing the same thing over and over again. Maybe they don't even expect different results. They just keep doing it over and over again.
Yeah, absolutely right.
Well, I think that's what happened with our overall development of implementing quality systems over time in hospitals. We started with a medication, right? So you have to start auditing. I need everybody to do an audit every year. It's a new regulation. So now we brought in an auditing software or auditing process. Hey guys, now you have to do incident management, right? Because now we have a new symptom, so we have a new medicine. So let's add that in. So now we're doing incident management. Hey guys, I need you to do a better job controlling your documents. Stop using opiates. Another medicine, document control, right? So on and so forth. So now we're taking 5, 6, 7 medicines. To manage the disease process of quality and risk in a hospital.
Then you're getting all kind of side effects from all these different medicines. Right?
And now you have more and more side effects, i.e. the gaps in between people-driven processes, right? Like it just doesn't make sense. Yeah. But eventually somebody comes along and creates a drug that manages the disease process without all of the side effects, because I'm not taking some medicines.
Yeah.
And that's what we're seeing healthcare be a victim of its own known progress, right? Or lack of progress, I should say.
Lack of progress. That's so true.
Yeah, absolutely. It's amazing.
Absolutely. I know we're at time right now. Just wanted to read a few of the comments that are going on in the chats, because they are lighting up from across, it looks like across the U.S. and beyond. So I just wanted to shout out a few people that have put in where they're from. Sonia's from Nelson, New York. We have Josh Hill from Hartford, Connecticut. We have Nikki, who is from Fort Myers, Florida, by way of Cleveland, Ohio. She left a comment earlier in the show about they're not nice, and I think she was referring overall to your overall auditors. So, Lurie put good morning. Not at all.
No. Yeah, they are not nice. Yeah.
Lurie put a comment in here. She said, "Good morning." She's from Lafayette, Louisiana, I believe. We also have Alicia from Charlotte. She said, "Great question, Dr. Brown." Hey, Alicia, great to see you. Have Kellen from Ontario. Lurie put in a comment that I wanted to read. She said, "You received several deficiencies and conditions. It's just not that easy." And I think she was also referring to your overall incident. We have Lakeisha from North Carolina. She said, "Ouch," and I think that's in reference to your audit in the $4 million.
Yeah.
Alicia left another comment saying budget should include standardized trainings to avoid such situations. I mean, that's too earlier. And then here's a question I wanted to ask to you. There's a question to you directly, Rob. And this is from Laura. She said, "Is there a grievance/compliant coordinator or department that can gather documentation and complete a comprehensive report, including recommendations and corrective actions for filing? It seems you spent many hours just trying to find proof of the resolution. Anytime there's a potential allegation, there should be a person to initiate the process and to see it through to completion." So You want
You're
to?
speaking my language, and that is what should happen. Yes. Unfortunately, that's actually another disparate system that I failed to mention. So they have a different platform that gathers, there's complaint data. And it does go to somebody in charge of patient experience, who then will take that data, decide whether it's a complaint or a grievance that they get to just choose. And if it's a actual grievance, then they will enter it into incident management as an independent incident, and then it goes to the risk track. If you are still listening, because I know we went over time, I fully acknowledge that that is a bad process. And that just speaks to there's a sixth system that we're using to manage quality. That added a gap, right? That's why we weren't able to prove really what we did. That grievance should have been a response within the same system, not sitting in somebody's email where, yeah, hey, we did at least respond to them, but that's all we got.
Correct.
If you're a CFO out there, if you're somebody who's head of quality, there is a better way. We try not to use this platform to blow our own horn, but Aperitisoft Healthcare has pulled the talents of some very smart people to give you the answer, the solution to this disparate system problem. And it does it extremely well. It's not as though we're not documenting. We don't want you to get that impression. The documentation is there, but it's happening in process. So as an incident is reported and then investigated and then corrected, all that is retained in one place.
Correct.
In Rob's incident before, Rob could have went in, found that one incident, and everything was right there at his fingertips. It would have been that easy. It's like that Office Depot or whatever it was commercial with the easy button. It was that easy.
I remember that. Yeah.
Yeah. It's that easy. So I know a lot of people say it's too good to be true. It's not too good to be true. We'd love to have a conversation with you about this.
Absolutely.
Feel free to reach out to us. If there anyone out there has questions that we haven't got answer to, we will. You can send us an email or contact Timothy directly. But what is out there right now, we will respond. We want to thank you for giving us your time again this month on a topic that is dear to our hearts. Next week, we're going to talk about leapfrog, or next month, I should say. Next month, we're talking about leapfrog, and how they're evaluating quality in hospitals and its implications in healthcare quality and risk. So tune us in next month, and we'll see you at that time. Thank you for joining us. Have a good day.
Take care.
Bye-bye.